Megan. So welcome to Grand Rounds. Some technical difficulties. Just imagine it like you're starting your day in the clinic and Epic's had an upgrade. You have no idea what to do. That's the way it was this morning. This is today's CME code. The All-Stars are starting to roll in, so I don't think I have to keep showing this slide of Tico. And we have some All-Stars today. Christopher Wickware, nominated by Charlene Moore. Sounds like the most wonderful person, and Chris will be getting a coffee cup. Great smile, Chris. Wayne Feng nominated Dr. Shakar in recognition of a patient's comment. And he is a wonderful peer person, and I'm sure he's got a 5.0 rating, which I do not have. That doesn't mean you all shouldn't. I'm old and cranky. So this is interesting. Melissa Freeman nominated the CT team. Apparently they were having a night like we were having here for Grand Rounds where they couldn't get the CT scanners going. And Leora Mulvin, Irving Arnold, and Kayla, with quotes, spent a lot of time troubleshooting and finally brought a portable CT down to the emergency room. So that's a first time. You better get Kayla's last name so we can get her a coffee cup. This week represents the Jewish celebration of Passover, which began on Monday and ends at nighttime on Tuesday. It represents the exodus from Egypt of the Jewish people more than 3,000 years ago. So to all our Jewish colleagues. For those of you who don't know, it's been 3 weeks since I've done this. Daniel Kahneman died March 27th. And please do not say you don't know who Daniel Kahneman is, even if you don't. Daniel Kahneman and his partner Amos Tversky invented the field of behavioral economics, came up with the idea, and I think coined the phrase heuristic, which is what causes you all to make bad diagnostic decisions when you're in the emergency room. Things like anchoring, attribution bias, availability, confirmation bias, framing, et cetera, were all developed by then. Prior to them, everyone thought the brain was like a statistical decision maker. After their work, they realized it was just total chaos and that you basically can't trust anything your brain comes up with. So died in his 90s, but an amazing influence on the field of economics and psychology. And his book, Thinking Fast and Slow, is a must read if you haven't read it. Andy Liu, future Daniel Kahneman, was in an article in nature.com about plasma p-tau to diagnose Alzheimer's. So you can put them on this really horrible medication called lecanemab that causes their brains to swell and bleed. So that will be an exciting time. On our research roundup, Nicole Bakos and Zachary Kafal were in the Journal of Clinical Investigation, which is a very highbrow journal, looking at the integrated stress response in neurons in dystonia. It's really important work. Shruti Agashi was part of a paper looking at detection of epilepsy and future bone health. And Heather and Andy were looking at epigenetic changes in life due to stress and how that might impact Alzheimer's. So in case you haven't noticed, it's a green world out there right now. What % of you have allergies to this crap? So it's like half. So the first thing to know, the new people, it's gonna last 3 months. The most beautiful 3 months where we live, you're basically pinned inside because this stuff is just horrible, unless you can take those antihistamines. But the most interesting thing is the green stuff is not the allergy. Everyone thinks it is because it coats everything, but the particles of the green stuff are too big to really get into your whatever tracks. But it's just that all the other pollens are out there too. So everyone blames the green stuff, even though it's gross. But yeah, it's awful. Again, today's CME code. And today's case is Dr. Lara Wadi. So Laura, take it away. Once you get this thing going, it does work better, I will say that, but it's still not working.
Good morning, everyone. I'm Lara, one of the clinical neurophysiology fellows. And for my case, we saw a 32-year-old male who was evaluated in clinic for episodes of unusual behavior and agitation and initially presented to another hospital. And these episodes were described as him trying to get out of bed, gets really agitated, sometimes falls, and often injures himself and tends to lose awareness during the events. The overwhelming majority are nocturnal. If they happen during the day, they can be preceded by anxiety, sometimes abdominal discomfort. They happen relatively frequently, 3 to 5 times a week, and are brief, 45 to 60 seconds. And on rare occasions, the next day per partner, he's had paranoid delusions and aggressive behavior. Past medical history was notable for complex febrile seizures and generalized anxiety disorder, and he has a fraternal twin brother with schizophrenia. And so while at the other hospital, there were some considerations for epileptic spells versus seizures versus parasomnia. So he was ultimately admitted to the EMU for characterization. And so I'll show you 2 videos of some of these events. And the first one occurs here out of sleep. He wakes up, opens his eyes, sits up, then very quickly here, we notice some oro-elementary automatisms. And then he starts rocking back and forth. He pauses for a few seconds, has some stereotypic movements of his hands, so dystonic posturing here. And I'll fast forward because he stays in this position for a while. Then eventually he gets out of bed. He falls, and this is not in our EMU. And he starts crawling on the floor. This goes on for a little while. And then here's another example, this time during the day, and he's awake for this. And so he sits up relatively abruptly, starts getting out, and then back into bed. Pauses for a little bit, gets back out. And then here, he'll start walking backwards. And then again, he pauses, and then we'll crunch over, go down to the floor, and start crawling again. Anyway, so these were recorded in EEG and were not non-epileptic spells. These were seizures. And the interpretation was that they were focal impaired awareness seizures that originated from the right frontotemporal region. He continued to have frequent seizures despite trying 5 anti-seizure medications that were appropriately dosed. So he was referred to us for pre-surgical evaluation. So his brain MRI showed right mesial temporal sclerosis, and he had neuropsychometric testing, which showed deficits in executive functioning, visuospatial planning, learning, and memory, suggestive of dysfunction in the bilateral frontal and temporal regions. And he also got a PET, which showed hypometabolism interictally in the right anterior temporal region. And so we had 2 major hypotheses here for his seizure focus or his epileptogenic zone. One based on his imaging, his EEG interpretation, and his PET scan being that these seizures may be originated from the right mesial temporal lobe, but then based on the hypermotor semiology, the rocking behavior, that these could be mesial frontal, the overwhelming were nocturnal, and potentially originating also from the cingulate. And so for this reason, we recommended stereo EEG for further localization of the epileptogenic zone. And this was his implantation map. He had a dense implantation in the mesial temporal lobe, in the insula, the cingulate, and the orbitofrontal region. And so here's a very scrunched up version of a typical seizure that he had, and all his seizures were similar. And I'm only showing the relevant channels where we see ictal activity. And so interestingly, we see that the seizure actually did start in the amygdala, the hippocampus, the hippocampal tail, so the mesial temporal structures. And this is where he says, I feel anxious. This was a seizure that we captured during the day out of wakefulness, something weird in my stomach, like I'm having an aura. And then eventually the seizure spreads, the anterior cingulate, the anterior mid-cingulate, the frontal operculum, the gyrus rectus, frontal pole. And this is where he starts having the hypermotor behavior and he starts rocking back and forth. And the seizure actually ends over the mesial temporal structures and continues over the frontal region. And so we concluded that his epileptogenic zone was actually in the amygdala and head of the hippocampus. And this was consistent with the aura that he had, the rising epigastric sensation, the anxiety, and some of the oro-elementary automatism. And then the hypermotor behavior really didn't kick in until his seizure propagated to the cingulate and the mesial frontal region. So this was his symptomatogenic zone. And then on rare occasions where he would have the paranoid delusion, so that was consistent with postictal psychosis and not PNES. And ultimately, multiple options were discussed, but he was felt to be a good candidate for an anterior temporal lobectomy. So some of the take-home points here is that his diagnosis is consistent with sleep-related hypermotor epilepsy, which was previously known as nocturnal frontal lobe epilepsy. The diagnostic criteria for this are brief seizures that have stereotyped patterns with abrupt onset and offset. And the most common clinical manifestation are hypermotor events, which can consist of elementary motor behaviors, so dystonic posturing, or distal stereotypies versus proximal stereotypies, where they have the rocking, kicking, for example, pedaling, and then the behaviors could be integrated in a good sequence that happens over and over again with each seizures versus non-integrated. And then although most of them occur out of sleep, some can occur during wakefulness. And then there can be other manifestations like vocalizations, autonomic features, and emotional facial expressions. And the interesting thing is that they don't have to originate in the frontal lobe. So not all hypermotor seizures that occur out of sleep are frontal lobe seizures. They can originate in the temporal lobe, such as in this case here. And the aura, the really important localizing clue. And the full semiology is actually the result of the early spread network of the seizure. That's it.
So I'd like to point out to everyone in the audience that Lara was a resident with us until last year, and in 10 months, she's now a star super expert. That was just an amazing presentation and a demonstration of expertise really matters. So great. And she's still got another year of training. Can you imagine? So today's speaker is Dr. William Bynum. He's an associate professor of family medicine, which is run by my dear friend, Anthony Vieira. I did not know Dr. Bynum before this. Like most people at Duke, he's got an amazing story. He served in the Air Force for 7 years, during which time he was deployed to my favorite country in the world, which is Djibouti, and also served on multiple other roles, including congressional delegations. Anthony was in the military as well, Navy, I think, right? Dr. Bynum's research focuses, much like my dreams, on emotion, shame, guilt, and pride, but his is in medical learners. He's a very sought after speaker. As I told him at the beginning, I didn't invite him, but it was like a consensus of a bunch of people in the department that we had to get him here this year, and I'm very pleased to meet him and to have him here. His talk, I have to say, this is just speaking to me, constructive shame. The Irish may be secondary to only the Jewish in terms of shame and guilt as ways of driving us. Constructive shame, does that mean being wrong? and that's something I experience, I'm an expert in medical education, what it is, how to facilitate it, and why we need it. So Dr. Bynum, thank you so much for being here today. And feel free to go on as long as you need because of our technical.
Okay, no problem. I should be able to keep it pretty tight. Yes, so good morning. Thank you for having me. You know, the first thing I want to say is just a big thank you actually to all of you. I don't think specialists, especially, and especially those of you that are work as hard as you do and are deliver patients as challenging as you receive, that you really don't get thanked enough, especially by primary care doctors who just deeply rely on people like you, especially among the patients that we struggle with the most. And so thank you for the work you do, sincerely. And I'm constantly in awe of it. One of the great things about being in primary care is you get to just be surrounded by people that are just so smart and smarter than you. If that presentation wasn't any indication of that, I don't know what is. So it's really cool to be in your presence. I've enjoyed working with your residents at times on this topic, and I'm excited to just give you a little bit of an overview of this concept of shame and shame engagement and what I'll just define as shame competence over the course of this talk. So I don't have any disclosures. And when I was, I completed my PhD at Maastricht University in the Netherlands, and they have a really neat tradition at the end of a dissertation or at the end of really the PhD process. When you propose a dissertation, it's long and it's, you know, a series of multiple studies, it's a book. And then they ask you in the process of creating that to distill down the entire body of work into 10 propositions. So you have 10 arguments or assertions that you feel equipped to make based on your work that really you need to be able to convince people of and argue of. And I really loved that distillation process so much that I actually start my talks with it now, because this is, rather than giving you learning objectives, this is what I hope I can try and begin convincing you of. And I honestly don't think it's going to take a lot to convince you of it. The first is that the first proposition I want to put out is that how we feel about ourselves as we deliver healthcare, we act in service of others in the way we do, has profound impacts on the nature of that service and how we feel about ourselves and the experience we have going through it. So this talk is going to center us on self-conscious emotion, the emotions that occur when we evaluate ourselves, how we feel about ourselves. And this is frankly not a space that is often, or ever at times, opened up in our communities. That's really one of the goals today, is to open up space for how we feel about ourselves. The second proposition is that, and I don't think I need to tell anyone in this room who's been doing this long enough, I don't need to convince you of this, but failing to achieve the lofty standards towards which we strive and hold ourselves and are held, that failure is inevitable. This is a more fun thing to tell like pre-med students and early med students, that you're going to fail over and over and over. We all know this. It's inevitable. And in many ways, that is something that we aren't necessarily prepared for. The third proposition is that shame, and I'm going to define it for you in a minute more succinctly, but this is an emotion that often lies at the heart of that failure. And it's because so much of ourselves is connected to the work we do, and therefore failure in that work really orients back to us as people and the way we know ourselves. The shame often lies at the heart of that failure. And the fourth proposition is that shame, while it's an important pro-social normal emotion, which I'll sort of hit on throughout the talk, it can really have profound negative effects on individuals, on relationships and teams, and on organizations, and ultimately, therefore, on our patients. So this is an emotion that comes with failure. Failure is inevitable. And at the heart of the work we do every day are our self-evaluations. And if you believe in, to some degree, in those propositions, then the fifth proposition is that we have to have constructive and healthy ways to engage with this emotion. I mean, it is an emotion that is active. It's having effects on us, on the people we serve, on our teams, yet it's rarely openly talked about or engaged with. And we need to change that reality and find more constructive ways to engage with it. And I'm going to define a construct towards the end that we call shame competence as a way to begin doing that. But before I can tell you about shame competence, I just need to tell you about shame. And I want to just define it from the outset. I could spend the whole talk going through the various ways that shame is defined and conceptualized. I'm going to just really distill it down to its basics, based on a leading set of theories in psychology that distinguish shame from other emotions based on the self-behavior distinction. So when we feel shame, we are engaging in a self-evaluation, and we deem ourselves to be globally unworthy, flawed. There's something deficient in us in a global sense, the whole person. So when we feel shame, we say things like, I'm not good enough. I am inadequate. I'm incompetent. I don't belong, etc. So there's a negative judgment of the self. Some psychologists and I very much agree with these perspectives as well, think that shame is always in relation to another person. So I see myself, I feel judged, I see myself as unworthy through someone else's eyes, even if that person is imagined. So it might be a real person, it could be somebody that we are sort of imagining in our mind. That this feeling of being judged is central to the experience of shame. So while shame orients towards stable, global, difficult to change or unchanging aspects of the self, guilt, I'm going to just briefly contrast with, it really relates more towards specific actions, behaviors, or circumstances. So when we feel guilt, we have failed to reach our standards. We see ourselves as distant from the person that we're trying to become, right, which can also occur with shame. But rather than blaming that distance on something global or wrong with us as an entire person, we blame it on something specific, something we've done, something that's happened, something that's situational or circumstantial that is modifiable theoretically. And the reason that these differences matter is that when we feel guilt, we naturally want to get ourselves back in alignment with that ideal. We want to do things to come back into, or closer to the person that we're striving to become. And when we blame something that can be changed, the natural tendency is to change it, to fix it. So guilt is a reparative oriented emotion. It is a pro-engagement, pro-healing emotion. Whereas shame has a different sort of set of action tendencies and outcomes. When we feel shame and we feel judged and we feel unworthy and we feel deficient, the natural tendency is to hide that. It's often to hide it from ourselves. It's certainly to hide it from other people. Right? It's a very painful place to be. It's vulnerable. We don't want to continue feeling that way, to be made to feel that way. And the natural tendency with shame is to try and disengage and isolate, withdraw, or at times it's to act out in anger or blame or defensiveness to repress that shame. So the critical caveat here is that while shame does tend to be or can be more destructive and more problematic, particularly in learning, it is an important, normal, evolved emotion. We need shame in a functioning society. Frankly, we probably need more of it in certain arms of our society, politics notwithstanding. We need to be able to adhere to social norms and bounds, and shame helps us do that. But it can be easily pathologized or weaponized. It can run amok very, very sort of discreetly or overtly, and that's really the type of shame we're talking about today. So I'm gonna help paint a picture of shame in another way by telling you about first a metaphor that we use. We've sort of conceptualized this incredibly complex emotion throughout our qualitative research through the metaphor of fire, and shame being sort of a reaction that can have major effects on the substrate that it affects, and that it is often sort of triggered by a spark, and then amplified or exacerbated by various characteristics in us or factors in the environment. So all this work started for me when I was a resident. I'm just going to give you the abbreviated story here, the real abbreviated story, but it occurred when I was early in my second year of residency on a labor and delivery rotation. And I was at a place of insecurity about skills, and yet sort of persistent insecurity, growing responsibility, which anybody that's been in that role knows exactly how that feels. It's very vulnerable, and you're just sort of waiting for the other shoe to drop. It was a not particularly kind environment that I was working in. It was certainly not one where vulnerability or any display of emotion was even allowed, certainly not encouraged. So there's a lot of posturing and stoicism, and also just some bad behaviors that were happening in that environment. And then in the midst of sort of this insecurity and self-doubt and hard work, I was working my tail off. A patient came in after a 24-hour shift towards the end of it, having a placental abruption. Long story short, I was sort of almost like ushered into the room as an opportunity to practice a vaginal vacuum-assisted delivery in the midst of this obstetrical emergency. So the baby was in severe distress. There was a bad hemorrhage. Its head was crowning, and it needed to be delivered ASAP. So I found myself at the foot of the bed or the perineum and passing the vacuum to the baby's head in just almost like a whirlwind of activity. A lot of people in the room. And I delivered the baby successfully, thank God. I honestly don't know what would have happened if I had hurt the baby. The baby did okay, and that ultimately saved me in a lot of ways. But I caused a really severe injury to mom, really severe, and it was one of those sort of situations where you live in fear of it. as a trainee, as a physician, as a healthcare professional. And it was like immediately everybody knew something had just gone wrong. I knew first and foremost, but everybody knew. It was kind of like almost a hushed tone around the room. And therein started like a pretty significant emotional response for me. It was initially one of fear, anxiety, shit. What did I just do? Like intense urge, like primitive urge to disappear. Like I wanted the ground to just open up and take me with it, right? And just be gone from that moment. It was so painfully exposed. Like I was sitting under like a bank of hot OR lights. You know? And one of the pieces of imagery I have in my head as I recall this experience, which is so painful to think about, was thinking about the people around me and their eyes and what their eyes revealed. Like horrified or shocked, disappointed or let down. I don't recall any kind eyes, but I was also not looking for kind eyes. And the only thing I knew to do was to leave the room. And I just handed the baby off in the vacuum and the obstetrician took over and I just sort of quietly left the room, which is also not something I would have usually done. You know, so I'm really out of sorts. And in the process of trying to figure out what to do next, I just sort of in a daze, literally, find myself on the other end of the hospital in a meditation room on the other side of the room, the other side of a chair in the corner, crouched down. And I was there for a matter of, someone sort of found me. I was literally hiding. I didn't realize I was hiding until much later when I told the story. And I was like, wow, I was hiding in there. And that's where a lot of that initial emotion from this trigger in this sort of bustable environment catalyzed quickly into a much more significant emotional experience. And this was the one that no one saw. But that evolution of the emotional, of the shame, this was shame, and I learned it later, was when the self-evaluation took hold. That's when I was like, oh my God, what does this mean for you? Not just what are you feeling emotionally, but what does it mean for you? And that's where thoughts of incompetence, worthiness, feeling like I had a strong resident. I was sort of a golden child resident, which I don't recommend. That is a tough place to be as a golden child. I felt like that was all a mirage. It's like that here's the real me who hurts people, who doesn't deserve to be trusted, and who really in this situation of that so many people would have handled competently. And that thought process stayed with me for days, and really lingered for a lot longer than that. I eventually did recover, at least partially, and the recovery was aided by reaching out to a friend who was a resident of mine, having him talking me through the situation, going through step by step of what happened, actually with a decent amount of humor involved, and then him saying, look, that could have happened to me, could have happened to anybody. Here's how I see that situation. And it was much different than the way I was seeing it through my emotions. I also just sort of applied myself to figuring out what it was that I had experienced. Same time, I went through kind of a bad breakup, and turned out I had a lot of chronic shame related to that. And I was sort of trying to rediscover myself after that. And I came across Brene Brown's TED Talk, Ability, which I can't recommend highly enough. And it was like the fog lifted. It was like, oh my gosh, this is the emotion that I experienced. It's shame. And it was super painful, but it was so helpful to have a name for it and to have it normalized and almost be made acceptable. And so in the sort of the aftermath of what was, we called this in our research in residence, this isn't the only way shame occurs, but it is a way it can occur. That being a sentinel emotional event. I mean, it's one in which there's significant emotional morbidity for the person who, experiences the shame. In the aftermath of recovering from that, I, roundabout way through some mentors and getting kicked into the deep end of the pool, eventually of research, came to realize that there was very little talked about or researched about shame, not only in my environment, but in the literature. This was like a layering. It was almost like a present absence, because you could see it percolating through the literature in a lot of ways. You could see it around you, but no one was talking about it. No one was making it explicit or acceptable even. And so that led to a research question that really framed my dissertation and then the entire sort of early body of work with this emotion that we've done. And it's a fundamental question. We're not presupposing that medical learners experience shame in the same ways as psychology or college students or other other populations. We wanted to just understand this from a foundational level. And we looked at it across the continuum. So we looked at medical students, first medical residents, then medical students, and then pre-med students, because we started to see some evidence of some upstream influences that were salient well before coming into medical school, and wanted to kind of dive more deeply into those. We use this methodology. I'm only going to tell you about this for 2 seconds, but called hermeneutics, and this is such a powerful qualitative methodology. It's really challenging. It is steeped in philosophical underpinnings that I find to be really refreshing and actually practical, because it requires that the researchers bring their own experiences with the phenomenon into the data analysis and collection. So, rather than sort of detaching my own experiences of shame from this, they were actually brought in very explicit, reflexive ways to the data analysis. One of the things that hermeneutics asks the researcher to do, among others, is to constantly attend to the parts of the phenomenon under study, so in this case, shame, and its whole, or the essences of that phenomenon, its deeper meanings. Why do all these parts, why does everything we're researching and learning, why does it matter? Or its deeper meanings. And so I'm going to just present a brief overview of our data using this parts and whole sort of analogy. So these are some of the ways in which a few resident participants and medical student participants describe themselves. This is how we knew that we were dealing with shame, because in accordance with the theories on which our research relied, these are global negative descriptors of the self, and they're pretty harsh. This was a challenging. These are challenging studies to be a part of, because when we really started to understand how people felt about themselves as they went through these processes of learning, it revealed things like this, which we had to be able to sit with. This is also a good example of the self-talk of shame. Right? There's not a lot of specificity here. It's not like obvious what to fix or to work on fixing. And I point this out for a couple of reasons. One, to just show you what shame is, but two, because people are often going to come to you with their shame, and they're not going to say, "I'm feeling so much shame. Can we please talk about all this shame I'm feeling right now?" They're going to come to you, even if they don't come to you, they're going to use words like this. "I'm feeling incompetent. I feel like I'm not worthy to be here. I feel like I don't know how I got accepted. I'm feeling inadequate." And that's a clue to you that there is a deeper emotional experience happening at the level of the self. We looked at how shame originates. Where does it come from? And the parts of the origination of shame give rise to a lot of deeper understanding and inroads to addressing it. The first part that we're dealing with here is an individual. So shame is a uniquely individual emotion in a lot of ways. It comes about through our own self-evaluations, appraisals, and attributions. But critically, in our research, and this is heavily supported by a lot of sociological theory, it occurs as the person interacts with the environment around them. So shame is not just an individual experiencing an emotion. It's heavily contextually influenced. And an environment really matters when it comes to shame, both how it originates, how it thus manifests, and how it is engaged with thereafter. We looked at shame triggers. So the events that precipitated more acute shame. So the shame that someone could look back on and say, yeah, this is essentially how it started. And we found triggers, not surprisingly, related to patient care. So among residents, we had, of the 12 resident participants we had, 2 of them told found shame stories related to causing the deaths of patients. And the shame was really quite profound. It also could be showing impaired empathy to a patient. We had one participant who showed emotion to a patient, felt extremely shameful showing their emotions to patients. One that just would go home at night after a long day in clinic and ruminate about all the ways she could have hurt a patient that day, and then feel shame for the possibility of hurting a patient, seeing herself as capable of that, which is complex and frankly a bit fascinating. We found a lot of shame related to learning, and we broke this into kind of 2 categories. There's learning events that we would consider to be normal, inevitable, unavoidable, and even ideal in learning. Being wrong, struggling on a new task, struggling on a presentation in front of peers, having to go through remediation, Myers testing, things that as we analyze the shame, which could be pretty significant, along with those, we started to say, well, these are normal learning events, and yet they're causing intense emotional reactions. To the extent that people seem to maybe not be prepared for that struggle, or to have been holding themselves to such high standards that were unreasonable in a learning process that shame therefore followed. But we also found a lot of events related to learning that they're not enough, like being marginalized on the team, being made to feel welcome, being mistreated, being term is pimp that I don't like. I'm going to use it because that's what we know colloquially, but being questioned to the point of humiliation or to exert a power differential. That within learning processes in medicine, these events were happening. And what our research reveals is the profound emotional distress that can occur with them, like profound. We had one student who was sort of marginalized on a team and just low-level mistreated for her entire rotation as a clinical student, and she in trying to make sense of it, rather than being able to recognize this as mistreatment and observed, she had to reconsider who she was to make herself deserving of it, because that was the only way she could explain it, especially coming from trusted sources. And her conclusion by the end of the rotation was, she said, I started to wonder if I was autistic and I had never been diagnosed. That was the way I could rectify and understand the treatment I was receiving. I mean, that's profound. And yet that was the first time she'd ever shared that with anybody, right, in a research interview in a safe space. So it's important to recognize that a lot of the shame that people carry with them and bring forward is deeply held and is not expressed. And the person in front of you who you're marginalizing or mistreating or not making feel welcome may be having a really significant emotional reaction as you sort of oftentimes mindlessly treat them that way, or hopefully not, but intentionally. We identified a lot of shame promoters, we call. This is kind of like gasoline on a fire. It's like if there's a little fire starting, you pour some gas on it, or if there was a gas spill on the ground, then you light a match. These are things that either predispose shame or amplify its intensity or duration. These are things like possessing a fixed mindset, being a perfectionist, comparisons to others. There were environmental factors like lack of psychological safety, marginalizing influences, feeling or being underrepresented relative to dominant norms around you. That we have a long list of these. These are actually some of the more practical ways that we might begin advancing competence and constructive engagement with shame by, for example, working on the tendency to compare. Being an adaptive perfectionist where we respond to our failures of perfectionism maybe with guilt for more constructive response. By, working deeply and intensely towards true representation, true belonging, and true authentic self-expression in our environments. We then looked at, and this was my favorite part of the work, this was the truly phenomenological, I think, part of this program of work. What does shame feel like once it happens? It's there, what does it feel like? And the data was fairly complex, and we broke it down into these elemental components, and then we looked at the relationships across the elements, and then we looked at the essences. And I show you the elemental components just for really two reasons. One, to show you any given shame reaction in our research or in a person who experiences it, that doesn't have all of these elements present, but there were always multiple of them. And I just show you just to highlight the complexity of this emotion. It's just unbelievably complex. The second reason I show you this is that if you were experiencing any combination of these, and you're trying to learn something, or you're trying to apply yourself, or you're trying to focus, imagine the cognitive load that is expended by this emotion and the attempt to keep it sort of hidden from you or from others. And if you've been in a shamed state at any time, I mean, it's like the swirling, just milieu of, I'm going to show you a picture in a minute that describes what I'm talking about, almost like this here. That's going on inside your mind and your self-evaluation and all that. And yet on the outside, you're trying your hardest to just appear composed, and you're trying to learn, and you're trying to apply yourself and manage an impression of yourself, etc. So that's one of the reasons this emotion matters so much, because if that is happening, and if we can manage that in constructive ways, then the ability to engage ourselves more with learning, the cognitive load, increase opportunity for more sort of germane learning could theoretically improve. And that is an area for future study to really look at the effects of shame on cognitive load. When we looked at the essence of all this, why does this all matter? What we found across the data set, across the various shame patterns and elements, was that shame tends to be, and often is, a destabilizing emotional state. And I definitely experienced this in my shame, and I still do now when I experience this emotion. It throws us off our emotional axis. Some participants describe this as being unmoored or unanchored, sort of adrift, whereas I knew myself before, or controlled the way I felt about myself before. Now I'm just adrift at sea. Emotional vertigo, depersonalization, disorientation. There's just something destabilizing about this. And we eventually found, as we studied this in pre-med students, that it's not just an emotional destabilization, but also a destabilization of self-concept, identity, how we know ourselves, and self-esteem, how we feel about the person we are, how we feel about ourselves. That those can be undermined, shifted, and often, or sometimes, chronically changed when shame is present. So we worked with an artist. This emotion is not one that can or should be limited to words to try to describe it. It's so multi-dimensional and complex that we've actually found a lot of, just enjoyment, and also working with artists to try and depict its nature. So we worked with this artist in the UK that we do a lot of work with now, named Hannah, who's so brilliant and talented. And we asked her to take some of our qualitative data and depict one of the more common shame patterns we saw illustratively. And so this is a 4-panel series, and this is what she started with. And as you can see, and there's lots of ways to interpret this. It's actually fantastic for small group work, because 10 different people look at this maybe 10 different ways, and there's really rich discussion that can happen with it. But something's happening in the upper left corner in the teaching, maybe, or some sort of patient care setting. The first thing I want to point out here is that there's a power differential at play. As this person is developing some sort of an emotional reaction here, there is a change in the nature of that interaction, or the perception of that interaction as the emotion is building. And there's different ways to interpret what could be happening in this interaction. The artist, interestingly enough, sort of depicted who maybe is an attending or a more senior person, almost in a little bit of a subhuman way here. There's something a little bit off about this person's shape, a little scary, and just sort of disorienting. And there's an emotional reaction beginning within a power differential. You cannot talk about shame without talking about power, without talking about power dynamics. And this is where shame really finds its sort of more social, socio-environmental, and relational manifestations. Also want to just emphasize here in the image that there's an emotional reaction building here, and that reaction is what we call the affective surge, or an emotional upswell. This is kind of what happened to me. It often is just this kind of surge of emotion that feels really intense, and often we try to suppress it or manage it in some way in the moment. That there are often fears of judgment. Now, whether there is true judgment or not is often unknown, but there's a fear of it, or a perception of judgment, that the people around me are judging me as I'm being mistreated. Other people have interpreted this as not judgment at all, but almost like horror at the way this person's been treating, or bystander shame. Like but then there's fear, because no one wants to speak up and help this person, right? Because they're scared. The role of other people really matters. And then we found that there's this element of hiding, right? There's often an urge to go and hide that initial emotional reaction, to sort of manage it outside of view. What we found is that after that affective surge sort of quiets, and there's more room then for the self-evaluation. This happened in numerous of our participant stories. That often in either real or relative isolation, the thought process around what the self-evaluation starts to sort of generate, or at least gain steam and energy. And it would often start as sort of a set of questions or wonderings about oneself. What does this mean for me? Is there something about me that caused this, right? Is it because I'm incompetent or lazy or belong here? And that unchecked, developing self-evaluation can then lead to some identity dissonance, right? So the white coat being over here, suddenly the white coat represents something that is a little bit distant from me. And that it also often occurs in relative isolation. That if that thought process kind of is allowed to really take root and continue, it can then turn into more of a sort of a deeply rooted self-evaluation. Rather than sort of this voice in my head quietly questioning me, it's now sort of yelling facts at me. It's telling me things that I now believe. And this we found is sort of the shame spiral. And the powerful thing about this is that we found that oftentimes all it took was either cultivated internal ability or more often someone else to come in and reorient this self-evaluation towards something else to help resolve it relatively quickly. That even a sort of an active shame spiral could be pretty quickly resolved with the right intervention. And what that often consisted of was helping to unskew the frame of reference. This is a really common component of a shame experience as we've understood them. It's that my tendency in a shame state is to evaluate myself in ways that are discordant from what other realities might dictate. So for me, I felt like an incompetent resident who hurts people to the mom of the baby I delivered who I hurt. I later found out after never showing my face to her again, because I was too ashamed, it turns out, which was also shameful for me. I found out days later from someone taking care of her that she wished I had come by because she wanted to thank me for saving her baby in an emergency, and that I was the person that she saw as sort of the hero of the hospitalization. You know, or my friend who told me that just sounds like a bad outcome, and maybe it's a mistake. Maybe it's something that you need to work on more back use. You need more emergencies. You should have spoken up and said you had been awake for 24 straight hours. Right? All those things were not things that I was blaming at the time. That someone else was able to help unskew that frame of reference towards these other realities that could explain the outcome differently, and that did not have anything to do with me, the whole sort of wounded, broken person. So the reason shame matters is that these are just some of the prominent impacts that we found in our study. These are significant. I mean, this is an emotion we just can't ignore. And I'm biased, of course. I do this work every day, but we cannot ignore this because we're also working on these things from many other angles. I think shame is actually one of the most fundamental, foundational drivers of these things. And it's probably one of the best targets we have to make meaningful change. But we also found, and this is where there's a lot of hope here, that shame, when engaged with constructively, could lead to some positive outcomes. That these were things that are ideal in our learning environments, towards which we often strive, and they could come through this constructive engagement. And so the question that follows is, well, how do we mitigate, or even let's eliminate unnecessary shame? I'll comment about that in a minute. And then leverage that which remains for growth. We're never going to avoid this emotion. We should not. It's going to happen, especially as we deeply interweave who we are as people with the work we did. So this brings us to, I just want to show you this, just to highlight Luna, my colleague, with whom I co-founded the Shame Lab, which is the academic sort of enterprise through which we're developing training and more research. We've developed this concept that we call shame competence. And we see this really as it's a set of skills, principles, and practices. So this is not something that you either innately have or you don't. These are things that can be learned. And these are strategies and insights and awareness that can be learned within individuals and then applied throughout an organization. So what shame competence ultimately allows us to do is to recognize, acknowledge, engage with, and then with inducing shame in a way that sort of mitigates its destructive and then leverages its constructive potential. Okay, so I'm just going to give you a real brief overview of what shame competence entails, and then a few key takeaways for what you can begin doing to apply this within your environment. So the first pillar of shame competence, this is the most important one, and it's the one on which all other pillars are built, is the ability to, and the willingness to maintain awareness of the presence or the likely presence of this emotion. And so you can't maintain awareness of something you don't know about. And that's why I think a talk like this, I appreciate the opportunity to give it, because I think hopefully it puts this emotion more on your radar. Now that it's on your radar, you kind of got to think about it. Right? And it's not something abstract you're thinking about. It's the human emotion that probably all of you experience in some way or another. So in maintaining awareness of shame, have to consider the possibility that the situation in which we're involved or through which we're supporting another person may have caused shame. So if someone's reeling from a medical error, if they're struggling with a new task, if they have to get up and give an M&M and they get grilled, there's a decent chance they're feeling some shame. It's a chance, right? Not for sure, but there's a decent chance. Another way to think about this is, what is the likelihood that just this person in front of me might be experiencing this? And it's not that you see them as someone needing your help per se, or that they just got all the shame and needs to be dealt with. It's rather that when you think about how someone else might be feeling about their self, just treat them differently, right? I mean, if they could be feeling shame and you're about to go give them difficult feedback, you're going to get that feedback in a little bit of a different way than if they're not, right? And so what we're essentially doing here is just practicing enhanced empathy. We're putting ourselves in their shoes, and we're not just thinking about how they're feeling. How are they feeling about their self at a deeper level? And that is what this work ultimately calls us to do. And frankly, all of our interactions. The extension to patient care should be obvious here. That if we think about when our patients may be feeling shame, how that might be influencing their behaviors, and then we work with them in nuanced ways, we might have major sort of transformation of their engagement with their healthcare, their trust in us, the meaning we derive from those experiences. Shame competence requires and teaches and builds capacity for recognizing shame, recognizing the self-talk, recognizing some of the action tendencies, the tendency to isolate and withdraw, the tendency to lash out in anger or defensiveness or blame, the tendency to make yourself small. If you're aware of these manifestations, which actually can be quite obvious once you know what to look for, then we have an ability to better recognize when it's happening and then support constructive engagement with it. And that recognition is not just in other people, it's in ourselves too. So I have a series of things that I do when I feel shame. If they're not obvious right away, but often, always, they present themselves to me. And that's when I'm the most annoyed with myself, because I know now I've got to deal with the shame that I'm feeling. But I've sort of cultivated an ability to see what those manifestations are in myself. We've got to avoid inducing shame. This is a call to action in healthcare and in health professional education, that we need to stop intentionally shaming people as a pedagogy, as a way of motivating them to learn or to change their behavior or to assimilate. That while this has been used deeply as a pedagogy, with often well-intentioned in medical education, as Luna, my colleague, describes, shame is mercurial. It's like you're working with mercury. You don't know how it's going to react. You don't know how the person is going to receive that treatment and respond. And as one of our participants said, I wish I could have learned without all the emotional baggage of having to navigate the shame that was sort of induced on them. So we can teach people, we can push them to the highest levels of achievement and not shame them. It is absolutely possible. I think guilt is one of the ways we do that. We don't shovel guilt on top of them, but we also leverage the guilt that they may be feeling. And I'm going to tell you in a minute how we do that. The words you use matter, right? We have countless stories from research and anecdotes of people who feel career-long shame from one interaction from an attending that told them they were never going to be a surgeon, that they weren't good enough, or that you don't belong in this specialty. Lifelong shame that comes from one conversation. We have to be aware of the words we use, right? All the way down to the feedback we give. If someone is doing something unprofessional, it's not you're an unprofessional resident or an unprofessional colleague or unprofessional physician. It's that this thing you're doing is unprofessional. Got to get it. It's not that you don't have the hands to be a surgeon. It's that we need to work on your dexterity, right? In order to become a neurologist, you're going to have to adopt these certain skills. Not that you can never be one. When someone is exhibiting challenging behaviors because of their shame, react initially remembering that there's a person underneath those behaviors. So if they're being defensive or blaming or angry, before you react to that anger, remember that that person is probably experiencing something more deeply at an emotional state. When it's time to respond to those behaviors, try to respond to the behaviors though, and not the person. So focus on the thing that they're doing, the thing that needs to be improved or fixed, rather than the person themselves, because that is more likely to avoid a shame response, and also to avoid some of those reflexive behaviors of defensiveness, anger, and blame that can really interfere with learning and remediation. And then finally, is the way I'm about to interact with this person, is the way I'm teaching this person right now, is it likely to help them improve? I mean, that should be a first filter in my view. And for residents, you're all, whether you like it or not, in teaching roles, right? You have huge influence over the more junior learners beneath you. As you work with them, think about whether the way that you're interacting with them, is it likely to help them improve? And if not, we need to change it. And then if you inadvertently or accidentally shame someone, right? You know what to look for now, at least at a foundational level. And it seems like someone might be having a shame response to your interaction with them. Just apologize. Right? Make it right. Humble yourself. We grossly underutilize apology in healthcare. It is actually one of the best ways to build connection with someone, even when we may have wronged. And I think we need to utilize it more. Supporting folks who are experiencing shame or ourselves. So this centers on allyship, right? You can't just go support someone because you think they need it in the moment, and then you're one and done, and then off to the rest of your day. It has to come from a place of authentic concern for the person and caring and allyship. And you need to make sure that you care about them. And if you don't care about them, and especially if you're in academic medicine on your own accord, you need to think about whether this is the right profession for you. This is a profession of needing to care uniformly for other people. We need to help people normalize their emotions, right? Acknowledge that, you don't necessarily have to say this is shame. I find power in that, but you could say, I think you're experiencing something that's making you feel down on yourself or inadequate. And that's a real feeling. I know it's challenging. Once you kind of make it real for them, share experience of your own if you can. I've been there. I've felt this. It's brutal. It sucks. You're not the only person that has felt this before or even feeling it now. Shame often makes you feel like there's something wrong with you for feeling it. So being sort of drawn into a caring sort of shared experience can be really helpful. Help them unskew the frame of reference. So help them stop blaming the self and put the blame and the focus on something that can be fixed. Right? So for me, it was, hey, you need to practice vacuum assist deliveries. You need to be more assertive in speaking up when you're uncomfortable, et cetera. But stop beating yourself up for this. This isn't a problem with you. It's just a challenge of something you need to learn and improve. So I'll often say to folks, take the blame off of you and let's put it over here on something we can fix. And then once you've done that, it's sort of incumbent on you to facilitate some support resources. You don't have to be their therapist. You shouldn't be. And shame is often a hard thing to really help someone navigate through without experience. But getting them to a person or people that can support that is helpful. And then committing to being along that journey of improvement, engagement, recovery with them, I think it's really important. It's a longitudinal partnership here, not just a one and done thing. Finally, transformation. This is just, I'm just going to make a plug for this, taking this beyond just the individual level into the organizational level, right? So can't build shame competence in an individual level and have organizational processes and policies that are shaming people. It's not going to work. It has to be diffused, top down and bottom up. We need shame competent leadership. We need to look at the policies, practices, material conditions that are driving this, that are deeply enculturated and embedded. We need to advance this training across an organization and then disseminate what we learn. Interestingly, we're doing this work right now in unlikely initial groups in the UK. We're doing it in local police forces. We want to be more trauma-informed, shame competent, and trauma-informed providers there in social work, and then we're developing it for healthcare and health professional education. So I'll leave us, thanks for letting me go 5 minutes over, with the fourth panel from Hannah's series that shows sort of some sort of a depiction of shame engagement. And there's a shared experience happening here. There's processing of the emotion, not an avoidance of it, that is something that we carry with us in the future. There's an activation of another person's sort of prior shame, and ultimately there's community connection and belonging. So with that, I don't think we have time for questions. Okay, cool. But yeah. Okay. Thank you so much.
Questions?
I have not read it, actually. I'm aware of it. I've heard it's a book about shame. It says, yeah. Yeah, yes, yeah. Yeah, I mean, that's a great question. So this is where it's important. There's not a universal way to experience shame. There's not a universal shame propensity. A little bit of what you're talking about is what we call sort of dispositional or trait shame. So that's what is my tendency to experience shame rather than state shame. I'm in a state of shame right now. And we have to be careful about dispositional shame and making conclusions about whether someone is shame prone or not. That's sort of fodder for bias. I think that we all do bring in characteristics, self-evaluative tendencies, past experiences that may predispose us to diverse reactions to shame triggers. Some people may have, what we found, we're doing a study now on shame engagement, and what we're finding is that if you've been through shame experiences in the past and you have constructively engaged with them, that the ability to constructively engage with them again in the future seems to be enhanced. Yeah. Yeah, we had a story like that of a guy who, yeah, he was a prior military guy, and he was in a battalion in Iraq, and he was the commander, and 7 of his killed under his command, and he felt such profound shame then that he said nothing could make me come close to that in the hospital. And we've really tried to analyze that as is that a good thing or not, right? I mean, really, is that healthy or not? So some of our shame mechanisms are more defensive, are more repressive, and can actually be quite problematic. What we think is that authentic, open, supported engagement with shame is definitely the healthier way to go. So if you happen to be a shame-prone person, it's worth working on that or working with that, because it can wreak havoc. I am a shame-prone person, so I say that from my personal experience. It can wreak havoc. Yeah, so we're okay. So well, one, I mean, I'm going to applaud both of our websites here. The Shame Space is a little project we built with Duke in US and the University of Exeter. And it's where we accumulate a lot of our sort of the creative modalities we've used to drive shame engagement in healthy ways. So it's where you can find this. There's like 5 other graphic comics, the documentary film, the Nocturnus podcast. Does anybody know about the Nocturnus? So we co-produced a 10-episode series on shame with them. All of those creative outlets offer these really accessible inroads to learning more about this emotion, and then having your own sort of reaction to them. They also offer great ways to kind of, someone's really struggling with something, hey, go check this out, listen to it, etc. I think that we're developing this, and we need more training and peer support. So we're actually starting to work with a couple of residency programs here to develop shame champions in their programs, to equip them, and then build fundamental shame competence in all the residents and some of the faculty. So a part of which will be peer support. So if I think my colleague might be going through this, what do I do? How do I interact with them? How might I support them? I need a workshop with you guys. We can definitely cultivate that. Leaving here today, what I would tell you is the most best thing you can do is to be kind. Kindness is so helpful to someone feeling shame, because you often feel like you're unworthy of receiving it, or you're unworthy of whatever you don't feel worthy of. And to have someone just pull you in and just be kind to you and love you, that is so helpful if you're really struggling and real. So start there. Start with kindness. And if we all just infuse more kindness in the work we do, honestly, that's a fantastic place to start. It may be a good place to end this. I really don't want to be mindful of time. Are you still okay? Was there one more? Yeah. Yeah, it's significant. It really came up more in the medical student and pre-med studies, probably more just, well, factors related to the populations that we studied. I mean, underrepresentation, the way it organically sort of emerged from the data was more about, do I feel different or outside of the norms around me? And so things like race and ethnicity and sexual orientation, gender identity, religion, those were a part of that. But also it was, I went to a state school and everyone here seemed to have gone to an Ivy League. If I came from a part of the country that's underrepresented here, it wasn't just those sort of the more defined ways of being outside of those norms, but often perceived ways of being outside of the norms that mattered as well. And the way it could manifest was that in a few cases, it actually, that was the trigger for the shame. Actually, the trigger was when I walked through the door of this place during orientation or for my interview, I started feeling shame because I recognized I'm the only person like me here. What does that mean for me? And am I the product of some special process, or do I belong, et cetera? So even just arriving in a space is enough to feel shame. But what was a little more common was I come in, I feel that way. I may have these self-doubts. And then if I struggle in any way, if I'm treated differentially in any way, it catalyzes a more deep-seated shame. So whereas me, always in the dominant norm, my entire life, everywhere I've been, essentially, certainly in healthcare, I have never had to grapple with the fact that I'm not represented or that the system wasn't built by and for me. I can't understand how, except through the experiences of the people that I research and that work with, I can't understand what it's like to be an underrepresented person and feel shame. But what I can understand is the emotional privilege that I have, because I don't have to deal with that. That I don't have to deal with the potential shame of being, mistaken as anything but a physician, or of, being marginalized on the team. That is an intense emotional privilege that I get to experience. And the other side of that is the emotional sort of disadvantage that can happen. And it's not an inherent disadvantage. This is created and maintained by our environments, by our society, right? So there is a lot of potential constructive shame, engagement, growth, healing that happens through true, authentic belonging, the opportunity for people to authentically express themselves, right? So I can show up and just be myself here safely. There's a guy named Justin Bullock at the University of Washington who's doing awesome work on identity safety. He says it's more foundational than psychological safety. He said, am I safe being me here, not just speaking up, taking risks, et cetera? That if and when we begin to develop true belonging and authentic self-expression, there is the potential for a lot of constructive shame engagement that comes with it, or the sort of mitigation of shame that really shouldn't be a part of the experience. Yeah, I mean, but this is what inequity and injustice does at a societal level. It chronically shames groups that are marginalized. I mean, that's the point. Shame is used as a tool of oppression. It's used as a tool to maintain an existing power. And it's a very, very powerful tool, because it can become so deeply ingrained that you begin to believe in it. And then you put yourself in that repressed state. You keep yourself there. I mean, this is where Luna, my colleague, has done a lot of work in this space. She's a philosopher, and working with her has really opened my eyes to how this massive shame is beyond just this emotional experience, right? I mean, some people have said it's the master emotion, it's life organizing. I say it's society organizing in a lot of ways. So while that's a bit overwhelming as a researcher, it's also super exciting because it gives us maybe inroads to make these really wider level transformations. Anyway, I could talk about that forever. Thank you for the question.
Can't shame or low self-esteem be like a real driving force for people?
Yep.
So it's not all negative,
No,
right?
it's about how it's engaged with.
Yeah.
So but I think you have
I want you to remember that it's not, just because you have it doesn't mean it's over. That can be something that really helps drive you.
Yes, we just should never try to induce it. That's the key, right? We should never use it.
Anyway,
I guess so.
great job. Really, I hadn't even thought of it.